PLI.
Good evening, everyone. Welcome to the 127th episode of IBS CRC Initiative PG Teaching Program with a Difference. Today, we are going to discuss a lot about the newer glaucoma surgeries, and the star speaker for today is Dr. Divya. She is the consultant at Indira Gandhi Eye Hospital, Gurgaon, and for the discussion, as we know that each of our programs, there is important role of our mentors and the discussant. We have three renowned glaucoma consultants as a discussant for this topic. One is Dr. Satyan Nagamalai. Sir is the medical director at I Trust Hospital, Coimbatore. Then Dr. Ansu Khare. She is the consultant at Sudarshan Eye Hospital, Indore. And Dr. Praveen Subadhi, he is stuck somewhere in the traffic, will join us later. He is the director, Ruby Eye Hospital, Brahmpur. With this small introduction, I would like to invite Dr. Divya for her talk. Dr. Divya will going to show us some good PPTs and the videos regarding the talk so that all the PGs can easily understand what are the various steps and what we can go and what is much needed, because this is ideally a theory as well as the practical topic. Means most of the time person will ask, there will be a question on the newer glaucoma surgeries or what are the recent advances in the glaucoma surgeries. Almost everything will be covered in next 30 to 40 minutes. Dr. Divya, please.
Thank you, sir, for the introduction. I'll be sharing my PowerPoint. My slides visible?
Yes, visible, and you are audible too.
Okay. So good evening all. Today we'll be discussing about the glaucoma surgeries. So these are the topics that I will be talking on: trabeculectomy, GDDs, MIGS, MIBS, and NPGS. So before moving into the surgery, so we should know about the aqueous outflow pathway. So we know that aqueous flows 75% via the conventional outflow. So that includes the trabecular meshwork, the Schlemm's canal, the collector vessels, and the episcleral veins. And 25% via the unconventional outflow pathway that includes the ciliary body, the suprachoroidal space, and the venous circulation. So first surgery we'll be looking at it is the trabeculectomy surgery. So we know that it was first introduced by Keynes in 1968 and Watson in 1970 for the treatment of glaucoma, which was unresponsive to medical and surgical laser therapy. So what are the indications to perform the trabeculectomy surgery? So when the intraocular pressure is inadequately controlled despite maximum medical therapy, or when there's a glaucomatous optic neuropathy, or there's a progression noted in visual field analysis or OCT, or in case the patient cannot adhere to the necessary medical regimen. So the basic principle of any surgery is to try and bring down their pressures to a level that will retard the RNFL loss. So the principle involved in trabeculectomy surgery is bypassing the conventional outflow pathway. So wherein the aqueous is diverted into the subconjunctival space from where it gets absorbed, from where it enters the circulation. So this is possible only via small sclerostomy, which is created during the surgical process. So for that, we should also know about the anatomy of the limbus. It is very important because any incision is made at the limbus, whether it be a cataract surgery or be a glaucoma surgery. So here is the picture which showing the clear cornea, and this is the limbus, which has got a bluish hue because it houses all the angle structures, and this is the whitish opaque sclera. So any incision of the tissue is followed by a healing process. But for a glaucoma surgeon who is performing a filtering procedure, excessive wound healing can be detrimental, leading to failure of the surgery. But how can we prevent the healing from taking place? So we have to add certain agents like 5-fluorouracil mitomycin to prevent the healing process because this causes a fine balance between the excessive flow and scarring. So 5-fluorouracil comes in a dosage of 25 or 50 milligrams per ml, delivered over 2 to 5 minutes. And mitomycin C, which is commonly used agent, it comes in the dosage of 0.2 to 0.5 milligram per ml over a period of 2 to 4 minutes. So in the examination, they can ask you about how will you mix the mitomycin C in the exam, in the Viva questions. And it comes as a powder form, which you have to reconstitute with saline depending upon the concentration you want to use it for the patient. So mitomycin C is proven to be more effective than 5-fluorouracil because it causes more cell death than the growth arrest. So resulting in tissues that are relatively acellular and they are unable to respond to the healing stimuli. So before proceeding with the surgery, we also have to do a thorough preoperative evaluation, starting from the age of the patient. The younger the age, the more the vigorous healing response takes place. And in that case, we have to use the antifibrotic agents, although they should be used with caution in young myopes due to the risk of hypotenuse maculopathy. And any evidences of ocular surface diseases needs to be sorted out prior to the surgery. And of course, the general health status of the patient plays an important role. If the patient is having cardiovascular disease, a systemic hypertension or diabetes, so this makes the patient to be at risk of suprachoroidal hemorrhage. So patient has to be systemically stable before taking up for surgery. And similarly, if the patient is on anticoagulant therapy, then it has to be stopped at least 3 to 5 days prior to the surgery under physician's guidance, because it increases the risk of bleeding intraoperatively. So these are the anesthesias that we use. So ideally, a peribulbar is a better option. And for the examination purpose, they can ask you what are the modifications in trabeculectomy surgery. So for that, we have to know the steps in detail. So first of all, we'll fixate the globe with the help of a superior rectus suture, or we can go for a corneal traction suture. So what are the problems one can arise with a brittle suture? So there can be a subconjunctival hemorrhage or a hole in the conjunctiva. And with the corneal traction suture, so if we take a full thickness bite, so that causes a shallowing of the anterior chamber or distortion in the cornea. So this is followed by a conjunctival peritomy, which can either be a fornix-based flap or a limbal-based flap. So for the exam, they can ask you what are the advantages and the disadvantages of fornix-based and limbal-based flap. So fornix-based flap is easy to construct and you get a good surgical exposure. But the downside here is there is chances of early bleb leaks. Whereas on the other hand, the limbal-based flap, so here you make an incision, make an incision in the posterior part of the conjunctiva and slowly dissect anteriorly. So there is a chance, so the construction, it takes a longer time, first of all. And since there's a nick made in the posterior part, there's a chance of scarring taking place in that part. So that is called as a ring of steel formation. So normally the aqueous flows, the posterior flow of the aqueous is required. But here, since there's a scar which is limiting the posterior flow, so all the aqueous will be drained, concentrated in the anterior part, and there are chances of cystic blebs in the limbal based flap. So once the peritomy is done, it is followed by cautery. So excessive cautery can cause also focal thinning of the sclera, and it is followed by insertion of the antimetabolites. So ideally, mitomycin C sponges are used. And make sure that you count the number of sponges that you're inserting into the pocket which has been created. And at the same time, note the timing for the duration also, which you're for the duration for application. So then also the important feature here is the edges should not be come into direct contact with the mitomycin C. So depending upon the risk factors, you can adjust the dosage of the mitomycin C. So some of the complications with antimetabolites are thin avascular cystic blebs. There can be bleb leaks, hypotony, blebitis, and endophthalmitis. So once the mitomycin C sponges are removed, a thorough saline wash has to be given. So ideally with at least 30 ml of balanced salt solution. And if in case there is a mild bleeding vessels are noted, then you can give a mild cautery, and this is followed by a scleral flap, which either can be a triangular or rectangular or a trapezoidal flap based upon the surgeon's preference. So once the flap is dissected, it has to be dissected forward. So as you dissect, you will be able to appreciate the various demarcations. So initially you will be encountering a white line. So that marks the anterior extent of the sclera. Then slowly you'll be encountering a bluish gray zone. So that overlies the trabecular meshwork. And still forward, so you'll be seeing a translucent clear cornea, and that is the place where you have to stop dissecting further. So once it is done, you have to do a paracentesis. And paracentesis step is very important because it assists in gradual decompression of the globe and prevents the sudden AC collapse. So at this point, if you have planned the patient for a combined surgery, for example, with a phacoemulsification, you complete the cataract surgery, insert the IOL, and then inject pilocarpine to constrict the pupil, and followed by viscoelastic substance to dilate to form the AC. And then you have to place the stay sutures, ideally with a 10-0 nylon on the posterior margins of the scleral flap. So once that is done, you can do the AC entry followed by an internal sclerostomy, which is ideally done with a Kelly sponge or a 11 number blade, and then a broad-based peripheral iridectomy, which is important to be, because in order to prevent the ostial blockage and iris incarceration into the ostium. So some of the complications are bleeding, or if you are in the wrong place, then it can cause a vitreous loss. So once this is done, you have to immediately suture the scleral flap, either with the two fixed sutures or with one fixed and the releasable suture, followed by a watertight closure of the conjunctiva. So this is ideally done with a absorbable suture. So meticulous handling of the tissues is very important in trabeculectomy. So post-operatively, these patients are started on topical steroids, which are gradually tapered over 2 to 3 months, and topical antibiotics and cycloplegics and topical lubricants. So how would you assess the post-operative filtration? So you have to do a Siegel's test. So exams, they can ask you, what do you mean by Siegel's test? How would you perform it? Or what do you mean by a Siegel's test? So where you apply a fluorescein strip over the bleb with the help of cobalt blue filter, you will look into the for any frank leak. If not, then you just apply a little pressure on the globe to see if there is any subtle leakage. Second, you look into the bleb appearance, how the bleb is based on the height, the extent, the vascularity. So you should know about the Indiana classification as well as the Moorfields classification. Also, check the intraocular pressure with the help of GAT and do an anterior segment examination, assess the AC depth and also the fundus. So this is another favorite question in all exams where they can be given you can be given a scenario and asked you how would you manage such patients. For example, if the intraocular pressure is low and if the anterior chamber is flat, so what are the things that you can suspect? So in case of a bleb leakage, how would you manage a patient? So if there is a bleb leak, immediately you reduce the dosage of steroids, apply a pressure patch. If need, you can go for a large diameter BCL and a fibrin glue if needed. Otherwise, if there's a large hole, then you have to take the patient to theater and do a surgical repair. In case of overfiltration, again, you have to reduce the steroids, apply a pressure patch. If there is if the pressures are very low, again, you can do a compression suture. In case of choroidal effusion, if it does not involve the posterior pole, usually resolves spontaneously with oral steroids, topical steroids, and cycloplegics, and drainage is required if there is a kissing choroids or if there's a lens in the corneal touch. In case of shallow AC and high intraocular pressure, so how would you manage the patient? So first of all, in this scenario, you have to look into the PI which you have created. So if the PI is not patent and if there's a iris Bombay-like picture, immediately you have to suspect that there's a pupillary block and you have to go for a laser PI. If the PI is patent, look into the fundus. If the fundus is clear, you should suspect that, okay, the aqueous is directed, could the aqueous be directed posteriorly into the vitreous cavity, thereby building the vitreous cavity pressure, thereby pushing the lens iris diaphragm. So in that case, you have to immediately start the patient on aqueous suppressants. cycloplegics, because cycloplegics helps to push back the iris lens diaphragm. And if the pressures are not getting controlled, you have to go for a ND-YAG laser hyaloidotomy, where you have to make a laser of the anterior, disrupt the anterior hyaloid face. And in severe cases, you might require IZHV, which is iridozonular hyaloidovitrectomy or a pars plana vitrectomy. Suppose if the AC is shallow and the intraocular pressure is high, so see if the PI is patent. Yes, PI is patent, and then look into the fundus. But you are not able to see the fundus clearly. There's a dark choroidal elevation. Get an ultrasound done in these patients. So look into if you suspect there's a suprachoroidal hemorrhage, start the patient on topical oral steroids as well as cycloplegics, and do a repeat ultrasound serially to see if there's a resolution of the choroidals. If it is not getting resolved, then you have to wait at least for 7 to 10 days for the lysis of the clot to take place, and then you have to drain the choroidals. How about this scenario where the AC is deep but the intraocular pressure is high? What are the possibilities? So you have to suspect whether there's a blockage in the internal ostium. So the blockage, it can be either because of the iris, it can be because of the blood clot or the fibrin, or can be because of the vitreous. So you have to rule out all this. So blood clot and the fibrin usually spontaneously resolves on its own. It's based on the conservative management. Sometimes if the iris gets adherent on the ostium, you can go for a mild YAG laser to release the blockage, or sometimes you can go for a surgical intervention may be needed. So once the blockage is ruled out, then you have to think in terms of the pressure is high. So what could be the reason? Could it be because of the tight scleral flap? Okay, so in that case, you have to do a bleb massage and see. So the bleb massage should be done like seen in this picture, where you ask the patient to look down, and with a cotton tip applicator or with your index finger, just apply mild pressure on the side of the scleral flap that you have created, and then apply mild pressure so that the aqueous drains out. So in case if the pressures are normalizing, then you advise the patient to go for a digital massage at home, as in this picture, where you ask the patient to press through the inferior fornix. Suppose if the pressures are not getting relieved, even on digital massage, you have to think, so, okay, the sutures are very tight. So you can do a ALS, that is argon laser suture lysis, to release the sutures, or if you have used a releasable suture, you can remove it. And in case if even on argon laser suture, if suture removal, the pressures are not getting controlled. So this time you have to assess the bleb once again, see if the bleb is flat, look into the vascularity, think about whether the bleb is going towards a failure. So if that is the case, you have to try and salvage the bleb. So how would you salvage the bleb? You can go for a multiple injections of 5-fluorouracil, or you can go for a needling procedure with antimetabolites. So there's another entity called the bleb encapsulation of the Tenon cyst. So where the bleb appears very tense and firm. So you have to start the patient on aqueous suppressants and advise the patient for a needling procedure, or sometimes you may require a bleb revision. So this is the flow chart as I had already discussed. So the late complications include the bleb-related infections, which is blebitis or bleb-associated endophthalmitis. So the main risk factors are thin blebs with leaks or inferiorly placed blebs. So the common organisms are Streptococcus, Staphylococcus, and Haemophilus influenzae. So the patients may present with symptoms of severe pain, redness, blurred vision. There can be a foreign body sensation and discharge. And the bleb, this is the appearance of the bleb, which gives a milky white appearance. And sometimes the AC can be involved. There can be a hypopyon, severe AC reaction, or the vitreous can also be involved. So you have to stage the condition. If only the bleb is involved, it can be a stage 1 blebitis. If there's an AC involvement is there, so it can be a stage 2. And if vitreous is involved, it is stage 3 disease. So based on the stage, the management also varies. So for the blebitis alone, we start the patient on intensive topical antibiotics. Whereas in stage 2 and 3, you do a tap for the culture and then start the patient on topical systemic antibiotics. And for stage 3, you have to give intravitreal because the vitreous is involved intravitreal antibiotics. And if the infection is ruled out, then you can go for steroids as well. In severe cases, a pars plana vitrectomy is also required. So how will you optimize the success in a filtering surgery? So carefully selecting the eyes which are at not risk of failure. Discontinue the medications which causes preoperative inflammation like pilocarpine, prostaglandin analogs. Reduce the preoperative intraocular pressure maximally and follow a meticulous technique while handling the tissues. Always better to go for a non-tooth forceps to handle the tissues and closely follow these patients at least during the initial period to monitor the filtration. So now let's move on to the second surgery. These are the glaucoma drainage devices or the tube surgeries. So let me just first explain the structure of an implant. So here, this is the plate and which is anchored to the underlying sclera. And this is the tube which is inserted into the AC. And there are two eyelets placed anteriorly for the fixation sutures to the underlying sclera. So the principle involved is similar to that of a trabeculectomy, where the conventional pathway is bypassed and the aqueous passes from the tube into the plate, into the subconjunctival space, and then it enters the circulation. So how do you classify the glaucoma implants? It can be classified based on the type of the plate, whether it's a rigid or a flexible plate, or based on the type of material, that is a silicone or a polypropylene, or based on the type of opening, whether it's a valved implant or a non-valved implant. So the valved implant includes the Ahmed and the Krupin valve, and the non-valved implants includes the Barwilt, the Molteno, we have Adi, we have ACP, which is Ahmed Cleopath, and the recently launched false glaucoma implant. So the glaucoma drainage devices, all the tube implants are indicated in all secondary glaucomas, in developmental glaucomas, and in case of failed trabeculectomy surgeries also. However, it is contraindicated in eyes with severe scleral or the sclerolimbal thinning and extensive fibrosis of the conjunctiva. So the basic concept, I'll just explain the basic concept between valved and non-valved devices. So let's look into the non-valved devices. So if you see, for example, the Barwilt. So this is the non-valved device which has got a large surface area. So the larger the surface area, the capsule which is formed over it is also very large, and usually it is thin. Therefore, more the filtration takes place. So because they are valveless, so there's a high chance of early hypotony. So how would you prevent an early hypotony in such cases? So you have to occlude the tube. So either internally or externally. So internally, you can use a ripcord suture, or externally, you can ligate the tube by absorbable sutures like Vicryl, and also give the venting slits. For a no, valve device like Ahmed glaucoma valve, so the smaller the surface area, surface area is very small. So the smaller the surface area, the smaller the bleb formed, and the bleb which is formed is usually thicker. So there's a less filtration taking place. So this makes the valved implants more prone for a hypertensive phase later. So during this period, you have to start the patients on anti-glaucoma medicines at least few weeks to months until the remodeling of the bleb takes place. So how do you choose between a valved or a non-valved? So if immediately you want the pressures to be controlled, go for a valve device. If the valve surgery also fails, then the ideal one is a non-valve device. So I'll just briefly go through the video for a valve implant. So this is, you have to stabilize the globe again with the superior rectus suture, and then a corneal traction suture is applied. So go for a peritomy. Once the peritomy is done, remove all the adhesions, whatever is there. And then you have to go for a cautery to see to remove any bleeding vessels. Okay, so then this is the implant where you have to prime the tube. So inject saline to look into the outflow, like how fast the uh, water is gushing. And based on that, once that is done, so insert the plate inside the pocket which has been created, followed by fixing the plate to the underlying sclera. And finally, the tube also has to be secure to the underlying sclera. So now the next process is you have to insert the tube into the anterior chamber. For that, you have to create a track. So measure at least 4 mm in the caliper And then behind the limbus, you just make a mark. With the help of 23 gauge needle, you just create a trap. And as you go through the tract into the anterior chamber, just inject the helon in order to form the AC. And then now you have to trim the tube. You have to trim it in such a way that the bevel end faces up, bevel up position. And then insert the tube into the anterior chamber, followed by fixation of the tube at this part. So now you have to cover the tube. So either you can go for a scleral patch graft or a corneal patch graft. And then secure the patch graft to the underlying sclera, followed by conjunctival suturing. So the steps for the non-valve devices are also similar, except for the 3 steps, where because of the larger surface area, so you have to identify the muscles, you have to and place the implant and place the plate, tuck it beneath the muscles. So as I already mentioned, because they are valveless, there's a high chance of hypotony taking place. So in that case, you have to insert a ripcord suture into the lumen, or you can you can ligate the tube and then fix the tube to the underlying sclera. The procedures are same. You can go for a venting slits also in order to prevent the raised intraocular pressure. You can have a mild egress of the aqueous into the surrounding subconjunctival area. So the post-operatively, the patients are started again on topical steroids, topical antibiotics, topical lubricants, cycloplegics, and topical anti-glaucoma medicines if a non-valve implants are used until the tube opens. So the various complications that one can face while doing a tube surgery are hyphema. There can be a choroidal effusion. The tube can get plugged by the iris or by the vitreous strand. Sometimes there can be a corneal decompensation. The tube exposure. There can be, if you're trimming the tube, sometimes if the length is long, so this can occlude the pupillary area and can hinder the vision. Or sometimes the tube can be cut short also. There can be plate exposure and erosion. So this hypertensive phase, this is more common in patients who had been implanted with a valvular device. So it is defined as where the intraocular pressure is more than 21 millimeters of mercury, which occurs more than after 3 months of surgery. So why this occurs is initially the aqueous flows properly through the tube, so the IOP is well controlled. But after a few weeks, like for example, after 3 to 4 weeks, because of the surgical trauma and there's a continuous aqueous exposure, there's a fibroblastic activation in the Tenon's capsule. So this leads to a collagen deposition. So the capsule which is formed is very thick, non-porous, and the aqueous cannot percolate. So therefore the IOP rises. So even though the valve is open, the outflow is choked. So therefore, you have to wait till the capsular remodeling to take place. So over weeks to months, the fibroblastic activity starts decreasing, the collagen fibers will realign, and then the capsule becomes thinner and more porous, thereby allowing the aqueous to pass through. So these are the recent implants, that is the ACP. So there is a possibility that they can ask you in your recent advances examination, the ACP, the mid-clear path, which comes into 2 sizes, 250 and 350, and also the Paul glaucoma implant, which was recently launched. So they can ask you what are the changes made comparing Barwelt with that of the Paul's glaucoma implant. So the TVT study, where a tube versus a trabeculectomy study, it's a multi-center randomized control clinical trial, compared Barwell tube surgery with that of the trabeculectomy. And these were implanted in patients who had prior cataract or failed glaucoma surgeries. And these patients were randomized and followed up for 5 years. So the key results are the 5-year failure rate was 30% in tube surgeries, and trabeculectomy, it was only 47%. The mean IOP reduction was similar in both the groups, but the complications were higher in trabeculectomy group, and they concluded that the tube shunts were preferred in eyes with prior surgery. In PTVT study, which is the primary tube versus trabeculectomy study, which is again a multi-center RCT, where they compared the barbell with that of my trab with MMC. So this time they had implanted all these tubes and did a trabeculectomy in virgin conjunctiva eyes. That is no prior incisional surgery. So these patients were followed up for 5 years. And again, the primary trabeculectomy patients, they had lower failure rates and a very good attainment of target IOP. But the tube shunt surgery had very few early complications, but long-term higher medications were used. Therefore, they concluded that trabeculectomy remains the preferred primary surgery in virgin conjunctiva eyes. Now coming to MIGS, which is minimally invasive glaucoma surgery, and I think this they had asked recently in the previous DNB examination also. So it's a ab interno approach with a small incision on the conjunctiva and conjunctiva sparing. So it causes minimal tissue disruption. Therefore, it has a very high safety profile and rapid visual recoveries. Basically, it acts as a bridge between the medical management and the standard glaucoma surgery. So how do you classify the MIGS? So it can be classified. You have trabecular bypass procedures like eye stent inject, and hydrous. You have trabeculotomy with goniotomy, which includes the trabectome. We have the KDB, bang, GAT, and the Tenetos microhook. We have trabeculotomy, goniotomy, and viscodilatation, which includes the surgical systems Visco 360 and Streamline. And we have Omni procedures and also suprachoroidal stents like CyPass and the iStent Supra. So also based on the target sites, you can classify like whether it's targeting the trabecular meshwork or the subconjunctival space or the suprachoroidal space and so on. So basically, MIGS is indicated for mild to moderate glaucoma patients and contraindicated where you're not able to visualize any of the angle structures, or if you're not confident to see the angle structures, and in case of angle dysgenesis. So for a good MIGS surgery, you should have these three basic requisites: good anesthesia, a good positioning of the patient and the microscope rotation, and also good intraoperative gonioscopy. So ideally, the head of the patient is rotated 30 to 40 degrees away and rotate the microscope by the same amount. And then you have to align the coaxial light along the iris plane. So these are the various gonioscopes one can use. So ideally, Swan Jacob is a better option, but then depending upon the surgeon's preference, they can use any of the gonioscopes. And what are the desired characteristics while doing a intraoperative gonioscopy? So there should be a good clarity of the angle structures. The globe should be stable. There should be absence of DM folds. And you should be able to introduce your instruments and simultaneously do a surgical manipulation. So coming to the individual techniques, so we are going to talk about the trabectome, which is a TM bypass by tissue disruption. So here it uses a high frequency electrocautery, which is performed under gonioscopic guidance to erode the trabecular meshwork and the inner wall of the Schlemm's canal. So we have the KDBs, we have the Cahook's dual blade, we have the bang, which is the bent ab interneedle goniotomy, we have the Thanatos microhook. So all these three procedures uses a specific blade to excise the trabecular meshwork and inner wall of the Schlemm's canal. So all these are done under the gonioscopic guidance. And in the GAT, which is gonioscopic assisted transluminal trabeculotomy, it uses a proline suture which is introduced into the lumen, into the Schlemm's canal, and then you perform a trabeculotomy where you rip open the trabecular meshwork along with the inner wall of the Schlemm's canal. So depending upon the axis, you can go for a full 360 degrees GAT or hemi-GAT. So the main advantages are it forms a direct pathway to the Schlemm's canal, and it can be performed as a standalone procedure or can combine with the simultaneous cataract surgery and has a good visual recovery. However, the main disadvantages are hyphema, and also there's a risk of cleft closure from the residual trabecular membrane leaflets. So we have the trabecular meshwork bypass procedures without causing the tissue disruption. So these are the iStent inject, and the hydrous microstent. So a brief video about the iStent. So this is made up of titanium and around 360 microns. So here, if you see, this is the injector. It has got two stents which needs to be placed consecutively. So identify the trabecular meshwork, insert the eye stent in one position, and 2 to 3 clock hours apart, you have to place the second stent. So now you will be able to visualize how the aqueous flows through the stent into the Schlemm's canal. So we have this hydrous procedure. So this is made up of a flexible material called as nitinol. And you have three windows here. And this is the inlet, which faces the anterior chamber. So through this inlet, the aqueous flows into the Schlemm's canal. So basically they act as a scaffold to cause the dilatation of the Schlemm's canal. So a brief video about it. So if you see, this is the injector, which has got a tracking wheel. So you have to rotate the wheel to deploy the stent. So under gonioscopic guidance, you have to engage the trabecular meshwork, and then you have to, with the help of a tracking wheel in the rotatory motion, try to insert the stent into the Schlemm's canal. So there are other procedures which causes the aqueous outflow via the suprachoroidal space, like the CyPass and the iStent supra. But because of certain disadvantages like corneal endothelial loss, hypotony, shallowing of AC, choroidal effusion, unpredictable intra-IOP control, and explantation was also difficult in certain cases. So this CyPass was withdrawn from the market. So there are other procedures which enhances the aqueous outflow via the Schlemm's canal. So these are the ab interno-canaloplasty. We have the Omni and the Visco 360 and streamlined surgical system. So all these procedures, they employ a catheter, a microcatheter, which is introduced into the Schlemm's canal. So as you introduce, it will relieve any obstruction around it. And on withdrawal of the catheter, you just inject a viscoelastic substance. So this will dilate the Schlemm's canal as well as the distal outflow system to reduce the outflow resistance. So post-operatively, you have to start the patient again on steroids, topical antibiotics and lubricants, and pilocarpine is required if you're doing a KDB, bang and GAT procedures, because once the pupil is constricted, so you have to facilitate the aqueous outflow pathway, right? So, and also you want to prevent the peripheral anterior synechiae formation because we had made a nick in to create the passage. So there are high chances of peripheral anterior synechiae formation. So some of the adverse events are iris damage. Hyphema is a big problem. And there can be a peripheral anterior synechiae formation. There can be some endothelial cell loss and device malplacement if you're using stents. Now, moving on to MIBS, which is minimally invasive bleb surgery. It's a term which is similar to that of a MIGS. It's basically a MIGS procedure, but that creates a subconjunctival bleb. So it is ideally suited for moderate to severe glaucoma patients with a substantial risk of progression. So we have the Zen implant. It comes in various sizes. So it is basically meant for an ab interno procedure, but sometimes many surgeons have adopted an ab externo procedure as well. Ideally suited for refractory glaucoma patients in whom maximum medical therapy is insufficient. So here, if you see, this is the injector. It's made up of porcine, gelatin, and this is the injector. It comes as a single-use sterile injector, and it is used to implant the stent through the trabecular meshwork across the sclera into the subconjunctival space. So there can be few side effects or adverse events like transient decrease in the visual acuity and transient hypotony. So we have the pressure flow device, which is also ab externo procedure. So it's 8.5 millimeters in length. You have three parts. So this is the tail end, and here there are two fins, which helps to fit snugly into the track which is being created. So it is made up of a material called as SIBS, which is biologically inert. So it decreases the risk of post-operative episcleral scarring and fibrosis. So basically meant for glaucomas with an open angle. And so the initial steps are similar to that of a trabeculectomy. But instead of creating a scleral flap, you just create a tract, which is 4 mm from the limbus, and then you try to insert the implant into the anterior chamber with the help of fins that fit snugly into the tract that is created. So some of the complications that can happen is shallowing of anterior chamber, and there can be bleb encapsulation. So this is the express shunt, which is also an ab externo procedure. It is called a MIBS-like procedure. So this shunt, it is made up of a stainless steel. We have a bevel tip, and we have the spur, which prevents the device extrusion. There's a back plate, which prevents the device intrusion, and there's a relief port, which allows uninterrupted aqueous humor outflow. So the procedure is similar to that of a trabeculectomy. You create a scleral flap, but beneath the scleral flap, you inject the express shunt. So some of the complications that can happen is a shallowing of anterior chamber. There can be some bleb-related problems, device occlusion, device extrusion, and corneal endothelial damage. Moving on to the last part of the session. So this is a non-penetrating glaucoma surgeries, a brief mention about this. So this procedure, it facilitates the passage of aqueous humor through the trabeculum and Schlemm's canal, bypassing the juxtacanalicular meshwork, which is the site of highest resistance to aqueous outflow without opening the anterior chamber. So ideally, it is preferred for open angle glaucoma patients, but it is not that much suited for angle closures or whenever there's an extensive pars formation. And ideally, very low target intraocular pressure is not possible, not achievable by this method. And however, the learning curve is very high. So the main NPGS procedures are deep sclerectomy or viscocanalostomy. Just a brief mention about the steps of deep sclerectomy. So we have the superficial scleral flap is created similar to that of a trabeculectomy surgery, followed by a deep scleral flap. And then you have to bluntly dissect to unroof the Schlemm's canal, followed by cutting off the deep scleral flap. And then this is the Descemet's, trabecular Descemet's window, where you have to peel the GCT and the Schlemm's canal endothelium. And this is a step where you can apply a implant, for example, a Ologen or some implants to prevent the closure of the TDW. And then you can suture the sclera and the conjunctiva. So some of the complications that can happen during the surgery is because of the high learning curve. So there can be microperforations that can happen with that in the TDM. There can be high FEMA, high intraocular pressure, and there can be DMD. But if the intraocular pressure is not getting control, you can go for an ND-arc goniopuncture. Or if the IOP target is still not achieved, then you can start the patients on anti-glaucoma medicines or convert the surgery to a trabeculectomy or a tube surgery. So to conclude, there is no single best glaucoma surgery. It's only the right surgery for the right patient. Thank you.
Thank you, Dr. Divya, for elaborating each and everything so nicely. One thing means most of the PGs were asked about the different stages or the phases after the GDD implantation. Means in the initial phase, there will be a hypotony, then the hypertony, then it becomes to the normal. Okay. Dr. Chaithan, sir.
Yeah.
Yeah.
Divya, it was an excellent presentation. I was very happy that you emphasized most on trabeculectomy because PGs with the flow of most of MIGS and MIBS and all those things, people tend to forget trabeculectomy. So thanks for emphasizing TRAB more. So if they don't know TRAB well, or what are the complications related to overfiltration, underfiltration, then leaks, identifying choroidals, suprachoroidals, and all those things. And it is very difficult for them to adapt a newer technique or where they can end up having a complication and treating them. And TRAB is eventually a rescue surgery where whether it is a deep sclerectomy, whether it is ab interna, externa, you can eventually do a trab and escape and come out. Or even in a GDD, you can do a trab and come out when you have an exposure of base plate or exposure of tube. You can obviously remove it and you can do a trab and come out. So it was a nice presentation.
Thank you, sir.
Thank you. Dr. Ansu, would like to add something?
Yes, Dr. Divya, I would like to congratulate first. It was an excellent, very detailed talk. I think you have covered almost everything. If the PGs just go through your lecture, I think they'll be able to learn quite a lot. And most of the topics which are asked in the exams, you have already covered. One thing I would like to ask you also that when can we do the laser suturolysis? What is the time period when the suturolysis is effective?
So I would prefer to do it after like around 3 weeks. So even if I have to remove the releasable suture, I usually prefer at least 15 days. I would give a time period.
So you would prefer doing a releasable suture or a suturolysis?
Nine. I prefer a releasable suture because I have the habit of putting a releasable suture and remove it. So that gives a good intraocular pressure control also.
Dr. Saithan,
Yeah.
would you like to add anything? Like when do you
Yeah,
prefer doing?
usually it depends on what type of flap you create, whether it is a triangular or a rectangular one. And I generally make a triangular flap and I make an apical releasable suture. And I previously, around 10 years back, before advent of all those aggressive prostaglandins, postamides, and all these newer glaucoma medications, the fibrosis were less. Now, when you are not aggressive by end of 2 weeks, you eventually have a failed blood by third or fourth week, and it is very resistant for blood massage and all those things. So I usually put an apical suture, only one apical suture for a triangular flap. Check the intraocular pressure at the end of 2 weeks. If the pressure is above 14 or 15, then I end up releasing the only applied releasable suture at the end of 2 weeks. Nothing will happen.
I think 2 weeks is a good time actually to do either the releasable or the suturolysis because that time the fibrosis is not that much.
Yeah.
And if you do that, then it is effective.
Yeah.
One more thing, these new procedures, of course, the PGs need to know, but of course, they are not very popular right now. They have just been introduced, and I don't think everyone, even being the glaucoma consultants, are doing this everywhere in India. It's just been introduced. Very few are actually doing it. So it is going to take at least 5-10 years again for it to become very, very popular. So, yeah, Dr. Saithin, if you have to add anything.
We had a glaucoma meeting a month ago, and I was telling them or 12, 14 years back when I was there in Delhi for an international glaucoma surgical society meeting, they were advocating about primary tube. You don't do a trap, do a tube directly. And now everybody stopped forgetting all those thing after that TVT study where tube versus trabeculectomy. Still, trabeculectomy is the primary surgery and all those things. I also feel the same thing. MIGS is being projected more now, and everybody started attempting MIGS, but it do have a lot of complications. And I have seen a lot of. I generally do a Kahook, KDB, and tinnitus. It causes a lot of hyperemia, and I suspect a lot of fibrosis, cleft closure, fibrosis occluding the and trabecular meshwork area, and the intraocular pressure control over a period of time. I don't feel very satisfactory. There is an initial dose of around very good control for around 3 to 4 weeks. After that, I still have a doubt about whether these still works. And whatever damage you have done for around 90 degrees or 180 degrees, whatever area you do on the nasal side, because you generally sit on the temporal side and do it, those are irreversible. You cannot go and attempt again, and those angles are damaged already. So I still have a doubt, and you need lot of time to analyze. People should come up with high volumes of surgeries and outcomes. Only then we can really understand and advocate about these procedures. That is my take. And I still believe 90% of my still glaucoma surgeries are trabeculectomies. Only very clear, open angle, clearly visible cases I do goniotomies. Other than that, I stopped even doing GDDs. Yeah.
Very true.
Is still the gold standard, I think. Still the
Yeah,
gold.
you have to.
Yes. 100% since last 5 to 6 decades, we see the trap, and trabeculectomy is still the gold standard. And whatever the newer devices are, these implants are there. I think it's the time and the larger study will tell us means how cases they are, because most of these MIGS have a study and follow up of 24 months or 18 months like that, except few studies. But the
Yeah.
trap we saw it from 2 decades, 3 decades. Everyone who are in this field, and many of them are even more than the 3 decades. We saw that it was done by the previous surgeons, and now they are working so well. So what Dr. Ansu says is very true that TRAB is still the gold standard for all the glaucoma surgeries. Rest can adjuvant or even the time will tell us means how or what are the new modifications are the things which comes in these devices, but because we are seeing day by day it's also changing, means there is some shape, some design, then another company will come with another features. So hopefully technology which will help us, but still the tribe is the gold standard for the all treatment. And for the PGs it's, I think, very comprehensive webinar. Means Dr. Divya started from very basic, from the aqueous flow to anesthesia to each and every topic. So even they can listen it and make the notes as good as from the book.
Yeah, I still remember me doing 2 or 3 cases of express implant where you don't need to do a PI, where you don't need to do an ostium. Just raise the flap, inject the implant and come out, and suture and come out. But over a period of time, even that doesn't play a role. It can prevent iris plugging the ostium or ostium not adequate or something like that. But eventually, whether it is detrimental for the proper functioning of the blood is still a question mark. So it faded off. So lot of implants come and go, but the outcome has to be long lasting, or at least for quite a period of time for it to make a mark. One. Second thing is, Divya was very excellent in, as Dr. Deepak said, from anesthesia to. So case selection is very, very important for a trap, for a better outcome of a trap. One is case selection, second is tissue handling, third is post-operative management. When you have closed the conjunctiva after a trap successfully without any complications, you have completed only 50% of trap, or all those things are only detrimental of 50% of the outcome. Rest 50% depends on how you treat the patient. I see them weekly. Every week I see for first 4 weeks, assess the bleb, assess the dosage, assess the flow, and take a decision of early suture release or suture lysis. Only then the bleb survives. And the bleb has almost 2 to 4 weeks for it to be manipulated. Beyond that, even if you inject 5 or 6 5 fluorouracil opposite, the same side, this side, that side, doesn't work. Doesn't work at all. Failed bleb
Very
is always a failed bleb. All these 5 fluorouracils and all can revive few blebs, but not every blebs.
Very true, sir. Very true. So, Dr. Divya, we would like to take final comments from you about this PG initiative by IVSARC, and what was your thought or the first
First of
thing
all,
came
thank
in
you for the
mind?
opportunity, sir. And I would like because TRAB is a high-yielding subject, a topic for the exam point of view also, and also for the Viva session. So I request all the PG students, whoever is watching the video, to go through today itself and treat trabeculectomy in and out. Then comes the GDD, and of course, the latest advances like MIGS, and because MIGS was also asked in one of the exams, I believe. So
Yeah.
hopefully,
But yet be an event for the recent advances, these things are usually asked.
yeah.
So
Yeah.
at the end of the webinar, from the whole side of Team EIVCRC, I would like to thank Dr. Divya for the wonderful presentation, Dr. Ansu and Dr. Satan for their expert inputs, and also Tushar for coordinating all of us. He is the person every time calling us, reminding and making whatever the possible, and the support team Sunil for all the things. Thank you, viewers. Thank you, everyone. Good night, sir. Good night,
Thank
everyone.
you. Thank you,
Thank you,
Deepak.
everyone.
Thanks to
Thank you.
Divya. Thanks to Anisha.
Thank
Anshu.
you.
Anshu.
Ansu.
Sorry, Anshu.
Bye.
Thank you.
Thank you, sir.
Take
Thank
care.
you, sir.
Bye.
Thank you. Bye.
Thank you.
Bye.
Good night.
Bye.
Bye. Good night, everyone.
Bye. Good night.
Bye.